All right, thank you so much. Thank you for the invitation to speak at this summit. It's been a very enriching experience, and it's been really wonderful getting to meet some of you over the last day. Before I start, can you see my arrow? You can't. Okay, that's fine. We'll go without. Oh, give me a second. Okay.
Looking for this arrow?
Yeah, this is going to be really hard.
Here's your red dot.
Super. Thank you so much. Okay, can you all see this now? Super, super, super. I won't dance it around too much, but it helps to show you what I'm trying to show you in the pathology images. So as you know, pleural mesothelioma is a rare cancer arising from the mesothelial cells of the pleura. There's an aggressive tumor with poor survival. So early and accurate diagnosis is critical in order for patients to receive the appropriate treatment. However, the diagnosis of mesothelioma is very challenging. In my opinion, it is one of the most challenging diagnoses in pathology for many reasons. There's multiple pitfalls in the diagnosis of mesothelioma, and there's multiple mimics, both for other types of tumors that look like mesothelioma, but also benign entities that look like mesothelioma. So it's very challenging in pathology, and it requires pathology expertise. So it requires pathologists who've seen many cases of mesothelioma. So just briefly, in general, we prefer a biopsy in order to make a diagnosis of mesothelioma. But because it's invasive, not all patients can undergo biopsy. And so if we have a cytopathology specimen and that's all we have for the patient, we will do the best we can to make a diagnosis on cytopathology as well. So here you can see this is an example of cells in a pleural fluid specimen under the microscope with mesothelioma. And then here's an example of tissue, a tissue showing mesothelioma from a biopsy specimen. In this talk, I'm going to be focusing on how we approach the diagnosis in biopsies, but everything we do in terms of approaching the diagnosis of mesothelioma in biopsies, we also have a similar approach in cytology, although there are more limitations in cytology. So the role of pathology when examining pleural specimens is to confirm the diagnosis and to distinguish from other diseases. Pathologists also identify prognostic features in tumors that can help guide management decisions, and we also identify biomarkers in tumors to help guide treatment and or enrollment in clinical trials. There we go. So first, I'm going to explain how we diagnose mesothelioma. The first task we have as pathologists is to determine the origin of the cells. Are they mesothelial or are they something else? And the reason for this is that metastases to the pleura are more common than mesothelial primary tumors. We use morphology to look at the cells, but it can be very difficult on morphology alone to determine the origin of the cells. Here's an example of mesothelial cells that are lining the surface. And you see some areas here where mesothelial cells are a little bit deeper. These cells are very round and regular, and they sort of look like mesothelial cells. So based on this image, the morphology is probably mesothelial. But some metastatic tumors can have this appearance. In this example here, this is a very aggressive appearing tumor. It's very poorly differentiated, meaning it doesn't look like anything. The tumor cells are bizarre, and you can see tumor cells like this in a carcinoma, a lung adenocarcinoma, or a mesothelioma. We can't tell by morphology. So in most cases, basically all cases, we use immunohistochemistry to help us determine the cell of origin. And we always correlate with clinical and radiologic findings. It's useful to know, does the patient have a large lung mass and a history of lung adenocarcinoma, and now we're looking at a pleural specimen? Or does the person have diffuse pleural thickening and no mass in the lung? So immunohistochemistry is also referred to as IHC. Sometimes you may hear of it as referred to as staining. We stained the tumor. And this is a technique that uses antibodies to identify proteins that are expressed in cells. There are several antibodies available with high sensitivity and specificity for determining mesothelial versus carcinoma. Mesothelial origin versus carcinoma. So two antibodies that we use very frequently, I'm sure you've heard of them, are calretinin and WT1. They both are mesothelial markers. They're very sensitive for mesothelial origin. Calretinin, here's an example of a mesothelioma with positive calretinin staining, which you can tell it's positive because you see the brown color in the tumor cells. There are a number of antibodies that can be used to determine carcinoma origin. They include, this is just a few of many, Claudin-4, BRAF4, MOC31, and CEA. Here's an example of a lung adenocarcinoma, and I would not be able to make that diagnosis just based on this morphology, but I can see that it's positive for Claudin-4 by this dark brown color, and it's also positive for TTF1, which is a nuclear marker that's very specific for lung adenocarcinoma. So once we've determined that the origin of the cells are mesothelial, we now need to know whether the tumor, whether the process is benign or if it's malignant. This also is very difficult because many benign reactive processes can mimic mesothelioma. So this is an area of pathology that's very difficult. I can show you a few examples. We do look at the morphologic features before we do anything else. So in this example here, you see fairly bland appearing mesothelial cells lining the surface in a single layer. The cells are round and regular and a single layer of cells. This is most likely a benign process. In this example, we see tubular formation of tumor cells that are invading deep into the tissue. We also see them invading in the adipose tissue over here, these little white circles. So this is compatible with a malignant process. Under no circumstance would this be benign. But this example here is where it gets tricky. You see proliferation of mesothelial cells at the surface. There are some benign reactive processes where we get this piling up of mesothelial cells, and you can't tell without seeing deeper into the tissue if this is benign or malignant, because you need to see if there's an invasive component. But sometimes in our specimens, what we see isn't deep enough to assess that invasive component. And so in these cases, it's impossible for us to make a definitive diagnosis of mesothelioma versus a reactive process. Again, we have ancillary studies that can help us, which I'm going to talk about, and we always use clinical and radiologic correlation to help us. So there are several antibodies for IHC that also have high sensitivity and 100% specificity for mesothelial, for malignant mesothelioma. So this is a typo here. It should say malignancy. So the antibodies that we commonly use are BAP1, MTAP, and NF2. And what I mean by 100% specificity is that these antibodies are going to detect molecular alterations in cells. And if that alteration is present, that is 100% specific for malignancy. However, they're not perfectly sensitive because not all tumors have a BAP1 alteration or not all tumors have an NF2 alteration. So if we see the alteration, we know it's malignant. If we don't see the alteration with immunohistochemistry, we can't say whether it's benign or malignant based on that immunohistochemical finding. Here are some examples. Again, immunohistochemistry is brown staining. So in these tumor cells, you see no brown staining. So this is an example of BAP1 loss, which means the BAP1 protein is not expressed in these tumor cells. It's abnormal and it's compatible with malignancy. Here are some examples of mesothelioma with retained MTAP and NF2 expression, which you see by the brown staining. And then here are some examples of mesothelioma with loss of MTAP and loss of NF2 expression. So we use these to help us determine whether reactive proliferation or whether something's a reactive proliferation or if it's a malignant mesothelioma. Once we have a diagnosis of mesothelioma, we must identify and report prognostic features that are helpful for management. The most important is the histologic subtype, which I'm sure you are familiar with. We have epithelioid, where the tumor cells are round in shape, sarcomatoid, where the tumor cells are spindled in shape, and then biphasic, where we have a component of both round and spindle-shaped tumor cells. And this is very important because histologic subtype is prognostically significant, as you know. Patients with epithelioid tumors have longer survival compared to those with biphasic and sarcomatoid tumors. Also, in the era of immunotherapy, we know biphasic tumors tend to respond better to immunotherapy. So when the pathologist gives a report and gives the histologic subtype, it might be helpful in getting patients to the right treatment. Within the epithelioid group, there is a broad range of survival. So in recent years, we've identified ways to improve risk stratification of these specific tumors. One is tumor grade. So tumor grade has prognostic significance in epithelioid mesothelioma. Tumors with low grade are associated with longer survival compared to tumors with high grade and or the presence of necrosis. Necrosis just means dead dead cells, and we can see that on morphology. Additionally, tumors with pleomorphic features tend to have worse survival compared to other epithelioid mesotheliomas. And so pleomorphic features are just these bizarre, abnormal looking tumor cells. They're giant. They have multiple different nuclei with lots of different nuclear features, and one cell looks different than another. They don't look similar, they look very different, and that's what pleomorphic is. Finally, pathologists also have a role in identifying biomarkers in tumors to help guide treatment and clinical trial enrollment. We do this both clinically, but we also help in the development of biomarkers in our lab. So some of the antibodies we use to help distinguish benign versus malignant are basically antibodies against protein expression against genes that could be therapeutic targets. So both MTAP and NF2 are potential therapeutic targets, so we can potentially help identify tumors that might respond to those treatments, both with immunohistochemistry, but also molecular testing. And so we have next generation sequencing panels that detect 500 plus molecular alterations in tumors that in the future could be potentially useful for targeted therapy. So just to summarize, the role of the pathologist is to confirm a diagnosis and to distinguish mesothelioma from other diseases and benign entities. We identify prognostic features in tumors to help guide management, and we also identify biomarkers in tumors to help guide treatment and or clinical trial enrollment. So thank you for your attention. Yeah, so in our institution, about 30% of our patients have a diagnosis elsewhere before they come to us. But before our clinicians will treat the patients, they need to have MSK pathology review the slides. So the standard procedure is to have the slides come to us, we review them, and then we do send them back. We also digitally scan them before we send them back, so we have a record of those slides. Yeah.
Thank you, Dr. Sauter.
Thank you.